Well, it's a pleasure to be here. I'm happy to present a discussion of what the best consolidation therapy to use in patients with multiple myeloma. And I'd like to define what I mean by consolidation therapy, since it may mean different things to different people. But I consider it to be a short-term, intermediate, or high-dose treatment used to achieve further cytoreduction in the myeloma tumor burden. And this could be high-dose melphalan, either 1 or 2 courses. It could be 2 or 3 drug combinations at conventional doses, generally for 2, 4, perhaps as many as 6 different cycles. But it's meant to distinguish from what we commonly refer to as maintenance therapy, which is really continuous therapy. And, thank you, Sundar, for presenting this. I don't need to talk about this much, but basically, we use consolidation or some sort of consolidation potentially in both transplant-eligible and non-eligible patients. But the point I want to make is, it's been said before, therapy has really become better in patients now who are living 10 years or more. But cure, I think, is still elusive, and thus the interest in consolidation and maintenance strategies. But the effect of the particular consolidation depends on where you started after induction, and I'll explain to you more about what I mean by that. The fact is that other than transplant, there's few studies that have really looked at consolidative therapy after induction, and almost none of them have compared different consolidation regimens. And as previously stated, a deeper response to therapy does not always translate into improved survival. We all believe, in theory at least, that with more effective therapy with the newer drugs, that perhaps we can cure some patients, and I think this seems to be a continued worthwhile goal. But the fact is that CR does not always correlate with survival. Some have used molecular remissions and certainly shown that you can prolong survival or disease-free survival and reduce the risk of relapse if you achieve a deeper remission, such as a molecular remission. So one of the approaches that was studied was DCEP therapy used by the IFM. They used 2 28-day cycles prior to the high-dose melphalan. And suffice it to say that that did not result in any differences in overall response rate. But this was really not it was a comparison between induction in patients going ultimately to transplant, but there weren't any differences in response rate seen with this. However, when you looked at transplant itself was a bit of an equalizer. Despite a less effective induction and a lower CR rate, transplant improved the CR rate even in the less effective group, and after 2 transplants, almost equalized the major response rate, and thus you didn't see really differences in progression-free or overall survival in that particular study. Now, the study that was done by the Italians that Michele Cavo presented compared VTD or 2 versus 3 drug therapy. Patients all got a tandem transplant, and then they got an extra consolidation for 2 cycles of therapy. And while there was a difference, of course, in induction difference between the TD and VTD, after transplant, again, there was an improvement in the major response rate for the less effective therapy. And after consolidation, there was a smaller but some improvement. But this did, in fact, translate into differences in progression-free, although not differences in overall survival. Now, the HOVON trial, which has been mentioned before by Sundar, patients got so-called bad therapy or VAD therapy, got their stem cells collected, and then went on to either a single or a double transplant. And again, even though PAD looked better than VAD after high-dose therapy, there was a further improvement, although the difference here was maintained. And ultimately, as you know, with using the bortezomib arm for maintenance after that, they did see a difference in progression-free and overall survival. This particular trial that Hans Ludwig presented was VTD versus Cytoxan VTD with 1 or 2 transplants. And that trial, again, did not show major differences in terms of adding the 4th drug, but with the consolidation of transplant, the major response rates improved dramatically in both arms and translated into no real difference in outcome in terms of progression-free or overall survival. This was a single-arm trial that Reeder presented with the Cyborg-D regimen. After 4 cycles, patients got near CR, but again, after transplant, this increased to 72%. So overall, if you look at this sort of summarizes these trials, and I've also included the IFM trial, the initial pilot study at the bottom. But if you look at this, in every single case, after transplant, there is an upgrade in the overall or major response rate that is seen. And as you can see, the difference depends on where you started. If you use a regimen like that produced single-digit near complete response rates, this went up tremendously, a 200% increase in the near CR rate. However, if you used a triplet regimen that produced a 31% near CR rate, there was a further increase, but as a percentage change, it was not that much greater, although the absolute difference is still impressive. Thus, the description I mentioned about where you start determines the effect of the combination. And of course, the RD versus transplant, the problem with this trial was it was not a randomized trial, and there was no consolidation comparison. Patients either remained on R big D or R little d, or at the discretion of the patient and the physician treating, went to a transplant. And clearly, the outcomes look better with autologous transplant because of the selection bias. I don't think you can really definitively say that transplant is the way to go after RD. Now, the French did another study in which after their 1 or 2 transplants, patients got a 2-cycle course of lenalidomide dexamethasone as consolidation and then went on to maintenance or no maintenance. And that clearly improved the major response rate, in this case by 43%, just 2 courses of RD given after another maintenance, which was namely the transplant. This is one of the few studies that Anthony Palumbo has done that has actually compared consolidation strategies. RD induction was used for 4 cycles, and then a consolidation of MPR for 6 courses was compared with a tandem autologous transplant. And the CR rates were modest after RD, 13%. Not a significant difference after either tandem transplant versus MPR, but this did translate into improved progression-free survival, although at 4 years the overall survival is not different between the 2. These are some other trials that have looked at post-autologous transplant consolidation. I mentioned the Italian trial. This was another trial in which patients that were in a VGPR or better got 4 cycles of VTD, and they achieved higher rates of molecular remission. But again, this is yet consolidation after transplant. These are some studies that were done reported at ASH with VTD, high-dose melphalan, and then VTD again, from a 13% to 34% after high-dose melphalan, and then 53% with another cycle of VTD. But the point of this is, and one of the things I want to say is that all of these trials have looked at fixed numbers of courses of induction therapy, 3 cycles versus 4 cycles. But if you look at this, if you look at the data with VRD, for example, after 4 cycles of therapy, only a small percentage of patients have achieved a major response. to get the best response, patients had to have as many as 8 or more cycles of therapy. Here's a more potent regimen using the newer drug carfilzomib, and after 4 cycles of therapy with a higher dose than standard carfilzomib, 70% of patients had achieved a near CR or better. Thus, the point about when you're looking at the effect of your maintenance regimen, be it transplant or some other regimen, I think you have to optimally treat patients, and I don't think it's being done in most of these trials. As an example, again, here's the IFM trial with 3 cycles, then they got high-dose melphalan, then they got VTD afterward. And then they looked at, excuse me, I think this is VRD, I made a mistake here, but as you can see, they went from 23% to 42%, an 83% increase, and then 2 more cycles, they went up another 14%. But the point is that these patients probably weren't optimally treated with VRD before they went to their next therapy. But here we have a very large trial, an international trial between the US and France, looking at what? 3 cycles of VRD induction with transplant or not, 2 more cycles after high-dose melphalan or continuous VRD followed by maintenance. The only other trial that is looking at this issue is the BMT-CTN trial of 702. After a single cycle of melphalan, they're looking at a second high-dose consolidation versus VRD, and then a maintenance arm for this trial. So my point is, what's the best consolidation? It's unknown, but I think the best available evidence still suggests that melphalan and ASCT is still a standard of care. I think the current trials underway are not really going to answer the question of VRD consolidation, because I don't think patients are being treated to their best response. I think future trials would best focus on this rather than use a fixed number of cycles of therapy. And so this would be a proposal for such a trial. You'd look at a regimen such as CRD, carfilzomib, Lendex, but instead of a fixed number of cycles, patients should be treated to their best response. The patients that get a CR can then be randomized to either melphalan as consolidation or maintenance. The patients that don't get CRs could get a second consolidation, perhaps bortezomib, pomalidomide dex is one approach, versus high-dose melphalan and then maintenance. And this would really allow you to look at CR rates with optimum induction therapy. Thank you.